Hi, I want to talk about a topic called treatment-resistant depression. We call it TRD in the field. So treatment-resistant depression is a little bit of a mystery that I'll try to explain. So basically, being resistant means it's like resistant to the usual treatment. So what are the usual treatments for the depression? Well, the old standard for so many years is SSRIs, like Lexapro, Celexa, Prozac, Zoloft, Trintellix. So there's 8 SSRIs, selective serotonin reuptake inhibitors that basically bind to the serotonin site, stop the leak, and force serotonin to go forward like it's supposed to. So those are the most common prescribed antidepressants. Most doctors think that they're the best first-line agent. I disagree. I've disagreed for, let's see, about 33 years now. When Effexor XR came out, the first SNRI, serotonin and norepinephrine reuptake inhibitor, and then a lot of the time, not every time, I have people on SSRIs and that we've tried SNRIs and they don't tolerate them and we go back to, so it's usually we have to look at those 2 chemicals first when we're looking to think about depression. It also depends on the symptoms people are having. If someone's having no anxiety at all, just has depression with very low motivation, low energy, maybe Wellbutrin might be a decent first choice, which is an NDRI, so which is a norepinephrine and dopamine reuptake inhibitor. So it focuses really mostly on dopamine. And again, usually with Wellbutrin, I add it to something else. So most of the time, one of these 2, SSRI, SNRI, is the first line choice. Usually, maybe I would say probably 2/3, 3/4 of the time, SNRIs like Prestige, Effexor, Cymbalta are better than SSRIs because they're more complete, they do more. And there's also a myth, by the way, that these medications take a long time to work. That's just complete nonsense. The medications do not take 4 to 6 to 8 weeks to work, like a lot of doctors tell their patients. Just not true. Never has been true, and it's not true. So sometimes that's it. I mean, sometimes the SNRI Wellbutrin, I call the dynamic duo. A lot of people with depression, anxiety, that's it. That's all it takes. But let's say it's not going away. Well, let's say there's residual depression. Well, if that's the case, I look at the Wellbutrin and I look at see what kind of an impact Wellbutrin made. So if Wellbutrin made a good impact, but then all of a sudden it stops working as well, or if it just doesn't work that well from the beginning, then I start thinking about Glutamate and GABA. So there's a bit interesting, I think it came out a year or 2 ago, a medication called Auvelity. So Auvelity is a combination of Wellbutrin with dextromethorphan, which is actually a cough syrup, but they concentrate it, and actually what it does is it boosts the level of glutamate. So it's kind of Wellbutrin plus this together. And I've had a lot of patients with treatment-resistant depression that really responded well to it. And sometimes that's all it takes. But let's say we're still stuck. We've tried the antidepressants, we've tried Auvelity, and then let's say they either don't work or they don't tolerate them. So either of those 2 things are a clue. If they don't work, that means that obviously it's beyond just a regular depression. And that's why it's considered treatment-resistant. But if it's treatment resistant, you gotta wonder, well, maybe it's not really just depression. Maybe there's something else going on here. And that's what I found is often the case with a lot of people, is that the reason that the treatment is resistant is because it's not just regular, we call unipolar depression. So I think this kind of hints often that there's a bipolar element going on here. Now, if you've seen TV commercials about Rexulti and Vraylar, and now Caplyta, the message is, this is for major depressive disorder, and then you add it to an antidepressant, and you get better. And the reality is that they do work well. I do have a lot of patients on Rexulti, a lot of people on Vraylar, and they are very good medications. But where I disagree with them is it's not major depressive disorder, and the reason it's treatment resistant is because there's a bipolar element. So Rexulti and Vraylar are we call atypical antipsychotic medications. Now, when people get afraid of the word antipsychotic, because the vast majority of the time when I give them, the patient's not psychotic. And they're not bipolar that we can see, because when we see bipolar, we're looking for bipolar 1, where people spend a lot of money, they get paranoid, they get really unstable. Bipolar 2, they're hypomanic, so they still get on the high level, and then they get depressed and they get unstable. So basically, my argument with the companies is that their advertising is incorrect and it's false advertising. And then when I asked them, well, how can you justify the fact that an atypical antipsychotic works when you add it to depression? I say, how can that be regular depression? Because you're using antipsychotic. They have no answer for that. They just look at me dumbfounded, like, well, this is what the company says, and this is what the FDA, this and that, and so there's a lot of stuff that they can't say because of the FDA and government warning. Well, I can say whatever I want. But the reality is when you need to add something like that, which works great, it means it's more of what I call a bipolar depression. And bipolar depression is more difficult. It takes more medications typically and so the ones I use typically, and atypical antipsychotics basically bind to the dopamine site and kind of slow it down. Where Wellbutrin speeds it up, it kind of slows it down. And sometimes the combination is very good, or sometimes Wellbutrin is not tolerated, so we do this instead. So to work on dopamine, and that can work really well. Lamictal, the only antidepressant that really works on GABA, which also travels with glutamate. That's another one that can be helpful for treatment-resistant depression. But again, it's a bipolar medication, so it's also bipolar depression. So what I'm saying is when you get past the regular antidepressants, and they're not working adequately, there's something else going on. And most doctors, unfortunately, don't recognize that. They don't really understand that. They don't even sometimes understand why Rexulti and Vraylar work, or what the diagnosis really is, and so they don't really know. They'll give things that work, and that's great, but it would be nice if they kind of knew what they were treating and knew why it takes doing this for patients to get better. What if medications don't work? I had a patient, unfortunately, I had a conversation with her today, and she'd been to other doctors. I love seeing complicated and difficult patients, because it's a challenge. I love the challenge of figuring this out, and it's fun for me. It's not fun for patients, but it's fun to try to get patients feeling better. But unfortunately, she's tried the atypical, she's tried Auvelity, she's tried Lamictal, she's tried a bunch of things, and nothing works for her. So what do we do with her? Well, I told her that she's tried ketamine, that didn't seem to help. I told her the next thing is we call TMS, transmagnetic stimulator. Anyway, you sit in a chair and it kind of puts it's not like electric convulsive therapy where you're it's basically it kind of helps to kind of change the brain waves, and it's you have to do like 30 different treatments for 5 days a week for 6 weeks, something like that. So it's very involved as far as time, and it's not cheap unless insurance covers it. But it can be very helpful for treatment-resistant depression when medications fall short. Psilocybin now, the magic mushrooms, microdosing psilocybin seems to be helpful with some people with treatment-resistant depression. Ketamine can be helpful. They typically start it with IV, but it's also a nasal spray called. It's a nasal spray. It's called Spravato. And so if that works, sometimes they have a spray, and then whenever they get into a depression, they just a spray or two in the nose and come out of it. So that could be helpful. And some people try different supplements and vitamins, and variable results with those actually. But because this is really a chemical medical thing going on here. It's not a deficiency of supplements. It's a chemical imbalance of these things, and so the medications are really trying to balance everything properly. And again, so treatment-resistant depression, it's a condition, but it's not what people think it is. It's not what doctors think it is. It's not what people think it is, because it's, people don't understand why the treatment is so resistant. And it really comes down to, like, you got to have the diagnosis correct. And, and again, a scary statistic I've said before on the show is it takes an average of 7 to 10 years and 3 to 4 doctors to diagnose bipolar disorder. And that's a shocking statistic. Think about how 3 or 4 cardiologists, 7 to 10 years to diagnose heart disease, to diagnose diabetes, diagnose anything. What other profession would ever put up with it? None. Only in mental health and psychiatry would that exist. And that, a lot of the message of my show is doing things differently than most doctors doing it, because most doctors don't understand that it takes doing things in the right order and mixing medications together to do this right. And some doctors just push one thing to the highest level and do another. They're just very haphazard how they do things, and they don't take the big picture. They don't keep the big picture in mind. And that's what it takes to really do this correctly. So hopefully this helps. If you have any questions, let me know.